So thanks for having me. We're going to chat about UDSs and or urine drug tests, pardon me, UDTs. And you're going to be surprised. We can spend a lot of time. So just a note that this material is made possible through a financial contribution from Health Canada and the GPSC, which is a partnership between the Government of BC and the Doctors of BC, and that the views herein don't necessarily represent the views of Health Canada or the GPSC. This is me. I have no relationship with any of the financial sponsors. I should note, though, that I do receive an honorarium from the BC Centre on Substance Use for preparing content and presenting and contributing today. Also a note that the BC ECHO on substance use, specifically the opioid use disorder, has received financial support from Health Canada in the form of a SUOP grant, and that the program has received in-kind support from the BC Centre on Substance Use, a not-for-profit organization which hosts this program in the form of logistical support. And that all of this content has been reviewed for potential bias. It's been validated by a number of members of independent scientific planning committees, the College of Family Physicians of Canada, and approved for accreditation. So really quickly, the objectives that we'll cover today, so that I think the 6 points explain why we have so much to chat about. These slides are going to be made available to everybody on the call, as Lindsay indicated. A little note that's different from the last time that I presented this information, in that we are actually at a transition point. We are in the process of revising the guideline for clinical management of opioid use disorder, and that there will be some changes in the guidance document around urine drug testing. So we're going to highlight some of those changes in today's presentation, but wanted to draw your attention to that in case you're looking at the current copy and saying, you're wrong, that's not what it says. So we'll draw attention to the places where things might change. So, just a note again that urine drug testing should be used along with collateral information, taken into account what the patient is telling you, so self-report, clinical assessment, what is the big picture here. Clinicians really take that moment to emphasize and ensure that your patients understand that urine drug testing is done for all patients that are on OUD. It is not to police or to punish patients, but really to provide them with the safest and most effective care. Before initiating OUD, when you find yourself sitting across from the patient, provide your patients with relevant information about urine drug screens or urine drug testing, an overview of the process, expectations, how often they can expect to have urine drug tests requested, and then, if appropriate at that visit, explaining the difference between random and scheduled urine drug tests. And just a reminder that in the context of opiate agonist therapy, urine drug tests are used to confirm the presence of opioids or confirm opioid use prior to initiating OUD. They can be used to assess whether individuals are adhering to their opiate agonist therapy medications, confirm self-reported use of non-prescribed opioids or other substances that might impact patient safety or potentially increase overdose risk, confirm the presence of substances the patient may be unaware they've ingested. So as we know, the toxic drug supply is becoming more and more toxic, in part due to contaminants. So that can be a moment of providing education for your patients, and then also as a tool to evaluate how things are going. And when should we do these? When should we be thinking about these? So confirming illicit opioid use at baseline screening, determining clinical and social stability before making decisions about carries or take-home doses, a marker to see whether patients are taking medications as prescribed, and then of course screening for other substances. So let's chat a bit about scheduled testing and random testing. So we refer to scheduled testing as urine drug tests that are done basically when the patient comes in to see you. So the patient can kind of anticipate, I'm physically going in to see the doc. Very likely they're going to ask for a urine drug test. Randoms are exactly that. Patients are phoned and asked to come in to provide a urine drug test, or depending where you are, perhaps you fax a requisition to a lab and they go to a lab that's more convenient to them. And they can provide that sample within 48 hours. So a note that, as promised, we're going to highlight where things have changed a bit. The current guidelines say patients need to present for a random urine drug test within 24 hours. But really, when you look at what can logistically be done by many patients and how long are urines positive following use, that timeline has been extended to 48 hours. And depending on your patient practice, I think this will make a lot of sense. I know for my patients that have jobs with long hours, 24 hours was just an impossible ask. So 48 hours is really looking at working with the patient. Random urine drug tests are preferred. They're more likely to yield accurate results. It reduces the likelihood of sample adulteration or behavioral changes that could occur in anticipation of scheduled tests. And if patients aren't providing random or scheduled urine drug tests, it's time for a reassessment. It could perhaps indicate a return to use, non-medical use, or diversion, but it's not really an opportunity to engage in a punitive response. It's really an opportunity to explore why this has occurred or why this is occurring. And there should be a system within your clinic, or an effort to create a system within your clinic that there's fairly quick follow-up if a scheduled or a random urine drug test has been missed. So some kind of trigger for that. How often should urine drug tests be done? It's really the prescribing clinician's discretion to set that timing. You really need to think about patient safety, particularly now in the setting of COVID. Like, how often are you calling your patients to come into a public healthcare setting? Convenience, autonomy, all of those things need to play a role in deciding how often. And I think the biggest one actually is what is this information going to do for you? Like, how is it going to change your clinical management? Generally, the principle is that we do more frequent testing at the beginning of treatment, and then as we see a degree of stabilization, that can fall off to some degree. It should be done at baseline, and then of course, when there's any kind of clinical change that suggests that there's been a change in status. The general guideline that it's done monthly or during initiation and dose escalation. And there are going to be situations in which urine drug tests are actually quite difficult to complete. So telehealth being one of them, other situations, renal conditions. And so, if you can justify a clinical reason or rationale for less urine drug tests, that's great, but please do document it in your notes. And then the flip side is, if your patient is very forthcoming in regular and frequent ongoing substance use, and that you've got these sporadic urine drug tests that confirm that substance use, really think about whether you need to do it as frequently, of course, again, within that clinical context. So this is a little note again about what changes you're going to see. So this is the current schedule. And this is how things will change with regards to testing. So you'll notice some of the changes on the take-home doses, where I think a lot of us look at how often we need to do randoms. Suboxone or buprenorphine naloxone has really changed to 2 to 4 random tests per year. Methadone changed to 6 to 8. And if you recall before, it was 8, and then same with slow release oral morphine. And of course, I think that will prompt some people to ask questions about, are we actually giving take-home doses for slow release oral morphine, which we can circle back to later on. Within your notes, in terms of documentation, make a note as to whether the urine test you're documenting is scheduled or random, and create a habit of looking at your patients' urine drug tests and keeping an eye out for patients that perhaps should be having randoms, and note that in your notes as well. So the actual procedure, the samples should be collected following the procedures for supervised urine drug tests. And a supervised urine drug test is not a witnessed urine drug test. Essentially, it just means that the patient produces a sample in a designated location, and that there are certain elements like assigned or created for that designated location. So clinicians or clinics should securely store sample containers away from the collection area, and that an individual sample container is provided. Request that the patients remove extra clothing such as coats or bulky sweaters and leave any parcels, bags, stuff that, other samples of urine perhaps could be carried in, and that those items are left in a secured area. We don't want our patients to lose their belongings. Let your patients know how to provide a sample. Just because we see this done all the time doesn't mean that patients will naturally understand what's expected of them. And when the patient provides you the sample, just use a hand, and it can be a gloved hand, to check the temperature, and it should feel warm. So if you immediately are handed a sample and it feels very, very cold, that's something to follow up on. You wouldn't expect a fresh sample to be cold. You don't necessarily have to measure the exact temperature of the container. That can be a few extra steps that aren't required. And the guidance document, the actual fulsome guidance document, actually goes through what temperatures would be expected, et cetera, if you are looking into getting more details on that. So point of care urine drug test, this is what we do in our offices, right? This is like either the strips that you stick into the urine test, or some of us have those collection jars that have it built into the side. These are immunoassay-based screening tests. They use antibodies to either detect the presence of a substance or a class of substance in a sample. It's usually in the office, not done, somewhere off-site. When you requisition from a local lab, the standard Amino urine drug screen covered by MSP includes opiates, so morphine, codeine, and heroin, hydromorphone, amphetamines, benzos, cocaine, and methadone. And so if you are looking for other things, you need to actually put that on the rec. And really, this point of care is what's preferred as a urine drug test for patients on opiate agonist therapy. And honestly, the reasons is because it's quick. It's a rapid test. You get quick results. It's portable. It's easy to use. It can test for a bunch of substances at once. And it's relatively inexpensive when you compare it to laboratory testing. There are downsides, of course. The concentration actually makes a difference in terms of whether something is picked up by that immunoassay. It detects classes of drugs, and we'll chat more about that in the next few moments. So it tests for like benzos or opiates rather than a specific like benzodiazepine or a specific opioid like heroin. Cross-reactivity is absolutely a possibility based on the antibody detection. And you can't really tell like how much or how often a substance was used. And whether it was one time or infrequent use can't really be distinguished from ongoing use. And it's the one other thing is it's a little bit counterintuitive in that the majority of the products right now show 2 lines for a negative test and 1 line for a positive test. So it's a little bit about flipping your brain when you read those test results. So let's go through specific types of substances that you might see on the point of care, so the immunoassay antibody type tests. So when you're looking at opioids, and for most of us, that will be listed as either MOP or OPI on our testing, our point of care testing. It really detects the presence of opioids extracted from opium. So we're talking about heroin, codeine, morphine. They cannot reliably detect semi-synthetic opioids, so oxycodone, hydromorph, or buprenorphine, or synthetic opioids. So we're really talking about methadone, meperidine, and fentanyl in those cases. You can get point of care urine drug tests that have specific tests for methadone and the metabolite EDDP, for fentanyl, oxycodone, and buprenorphine. And I imagine most of us have moved to settings where we have chosen urine drug tests that have those abilities. But just knowing that the opioid test alone won't give you that information. You can get false negative results and cross-reactivity, which results in false positive results. And an example is positive urine drug test result for hydromorphone if morphine levels are super high. But it doesn't necessarily mean that hydromorphone's been taken. That's when a call to your local lab guy can be super helpful. And if you're a pictures person or a visual person like I am, this kind of explains why you get positives for certain substances and not positives for other substances, showing why you may get a cross-reactivity with hydromorphone and hydrocodone, and why you wouldn't have fentanyl or methadone picked up. So cocaine is the one test where we have a bit of comfort in our confidence of, yes, a true positive is a true positive, in that the point of care test is actually quite good. It detects the presence of either cocaine or benzoylecgonine, which is the active metabolite of cocaine. It is very reliable. There's very little cross-reactivity with any substance, and really when you see a positive test, you can be fairly reassured that this is highly predictive of cocaine use. There are no structural similarities between cocaine and other anesthetics such as prilocaine or lidocaine, so the other canes. This does not occur. And then on the other end of the spectrum, we have point of care tests for amphetamines and methamphetamines. And this has the highest degree of cross-reactivity. So, positive urine drug tests could result, could be positive due to sympathomimetic amines. So stuff we find in cold medications like ephedrine or pseudoephedrine. Cross-reactivity also occurs in other related and actually non-related structures as well. So there's an entire list available to you guys in the OUD guidelines that shows where cross-reactivity may occur. All right, so benzodiazepines, the difficulty here is that the benzo test for point of care best detect benzos that are really related to the metabolism pathway that we see for oxazepam. So that's going to include stuff like diazepam, chlordiazepoxide, which I don't think a lot of us are using, and temazepam. Common benzodiazepines like lorazepam, clonazepam, alprazolam have different metabolic pathways, and they don't actually cross-react. And so you'll often get a negative result for benzos when patients are on those benzodiazepines. And again, for the picture people or the people who like the visual, the visual representation, this shows us why you would get those negative tests with these commonly prescribed benzodiazepines, clonazepam, lorazepam, alprazolam. So, with cannabis, I think most of us have kind of shifted as to whether or not this is something that needs to be included. I think generally, urine drug testing for cannabis is not necessary. It may be included at the discretion of the prescribing clinician. A note that passive inhalation of cannabis is unlikely to trigger a positive result. That synthetic cannabinoids, so nabilone being the one that we would see most often, will not result in a positive immunoassay result, but that Marinol, so Sativex or dronabinol, contain THC, and that they can actually cause positive results. So something to consider perhaps in our chronic pain patients who may be accessing those medications. And that it does actually result in false positive results in many cases. So confirmatory drug testing, something that I've referred to earlier on, is something that's done in a lab, and you actually have to write the word confirm. So you can write confirmatory or confirm and then list the items that you're interested in having confirmed. The lab tests, if you write urine drug test, they're just going to do a point of care test that uses the same immunoassay. So you do need to write confirmatory. Once you do that, they will use gas chromatography mass spec, so GCMS, or liquid chromatography, so LCMS. This will give you the specific test result. And so one thing to consider is how will that information impact clinical management, and then also recognizing that that information will not be immediately available to you because you are going to send it off to a lab. So of course, confirmatory testing is far more sensitive and absolutely specific. It can find substances that are not included in your point of care immunoassay. It can detect concentration of substances in a sample. It can be used to confirm substances in the event that the patient self-reports drug use that's different from the results. And really that's in a situation that should be, again, that only changes clinical management. There are disadvantages to this testing approach, though. It is expensive. The results are delayed. You cannot make a decision in the moment with the patient sitting across from you. There does need to be some caution in interpreting the results because opioids do have active metabolites, as we talked about previously with confirmatory testing may indicate high levels of hydromorphone in settings where you have very high levels of morphine, which you might see in patients prescribed SROM. So what do you do if you're sitting there looking at a urine drug test that you didn't expect? It is a reminder that it is not the only factor that you need to be looking at when making treatment decisions. And before you do make a decision, have a look at the patient's medical records, have a look at PharmaNet, see if there's any possible cross-reactivity that may explain the test result in front of you. Chat with the patient about, what it is that you might be looking at. Often patients will self-disclose before you need to even start playing detective. And then use that as an opportunity to ask your patient about changing circumstances or life changes, and ask if the treatment plan that you have developed with them is actually meeting their current needs, like what needs to change, and then review the goals. What is it that the patient wants to achieve? Possible explanations for negative opiate agonist therapy on a point of care drug test. It could be a false negative. It could be due to missed doses. I think the one that most of us are worried about is a diversion. There's the possibility if a patient is perhaps on the tail end of a taper or something, they have a very low dose and have unusually dilute urine, that's a possibility as well. And if you are faced with that, have a chat with your patient, ask them if they're taking their doses regularly as prescribed, if there's any missed doses, if they're sharing their medication. Share the results with the patient and see if they, they have an understanding or an explanation. This would be a good time to order that confirmatory test or chat with your local pathologist colleague. Review and revise the treatment plan and the patient goals. If you are sitting there and you're really thinking there's a concern here, you may want to consider pill counts or a return to daily dispense for a period of time. And that if there are repeated attempts for diversion, consideration for daily dispense at the pharmacy is appropriate, keeping in mind that you may need to adjust the dose if the patient actually hasn't been taking it. All right. Okay. And again, unexpected results. Potentially water's been added to the sample. It's a synthetic sample. There are items available for purchase, fake urine online. It could be someone else's urine. There might be that substances are added to the sample. And again, I think you guys are probably picking up on the theme. Chat to your patients, show them the results, ask them, if things are okay. Are there circumstances that are affecting the substance use or their stability? Explain again the rationale for urine drug tests and that it's not meant for punitive approaches, but that it is a measure of how someone is doing in terms of their treatment plan. And then for the safety of the patient, once you've, gone through all of that other stuff, considering going back to a daily witnessed ingestion setting, at least for a while until stability is reestablished. Sorry about that. Okay. And, as always, you're not alone. If you're staring at a urine drug test and there are just pieces of all of this that don't make sense to you, the 24/7 addiction medicine support line is absolutely an appropriate resource to call. People who are frontline care providers for patients, and that includes nurse practitioners, nurses, midwives, pharmacists, and docs, can call that line and get some guidance. We're available 24 hours a day, 7 days a week, and always happy to chat with you. These are some of the BCCSU documents, as well as some other documents that explore urine drug testing in a clinical setting, and the references that will be made available to you guys.